Good evening, everybody, and a warm welcome from Finland. My name is Nina Hoven, and I'm the president of ADHD Europe. It's my great pleasure to welcome you all to this webinar organized in collaboration with UNITHYDIS and ADHD Europe. Today, we are gathered around an important and timely topic, exploring the lived experience of ADHD as a form of neurodivergence. We will begin with an introductory talk by Saskia van der Oord, a professor at Leuven University, who will provide valuable insights into the subject. Please note that the presentation slides will not be shared afterward. Now I will give you the virtual microphone. Saskia, you are welcome.
Thank you, Nina, for this kind introduction. Let me pull up my slides. Today I'm going to talk about neurodiversity and applying the neurodiversity framework to ADHD. Here are my disclosures just for you. I've done some co-development on behavioral interventions and been an advisor for the ADHD Guidelines and an advisory group for the Minister of Health in Belgium, and also received reimbursement from Medici. But today I'm going to talk about the neurodiversity framework, which is a framework that is really stems more from the autism field than from the ADHD field. And most of the work to date has been done on autism and neurodiversity. And how does this neurodiversity framework, did it come about? Actually, in the end of the 1990s, in the community of autistic people, people were not happy with the medical framework of how autism was described, and also not happy with more the social view of autism, that it was something that was caused by how people were raised or by our society. And to find sort of a middle way between this, the neurodiversity framework arose from the community of autistic people. And what we see is that this framework really hasn't been applied a lot to ADHD. So that's what I will do in the first bit, try to apply this framework to ADHD, explain a bit about neurodiversity. A lot of people already know about neurodiversity, but I will also explain what it is. And to really see how does it match people's lived experience, so people with ADHD lived experiences. How does it relate to their lived experience of ADHD, their mismatch with their environment? How does it match with their experience of having or getting a diagnosis of ADHD, with taking medication, and what the implications of this framework would be for support? So, what is neurodiversity? Neurodiversity assumes there's a difference in way people think, feel, and learn, and that this difference is not good or bad, that it's a value-neutral difference. And in that sense, neurodiversity includes everyone. Within this whole neurodiversity framework, because it's a framework, it's not a diagnosis, there are different neurotypes of different groups of people who identify as diverging from the dominant social standards. And one of these neurotypes is autism, and another neurotype is ADHD. Within also this neurodiversity framework, there's a neurodiversity movement. And that is the idea that people that diverge from these normative standards or neurotypical way of doing and being, that is considered a minority group, and that as for every minority group, that it's good to advocate for people's rights, and that also it's good to fight exclusion and discrimination. So these are people of the neurodiversity movement that do this. As I said, it sort of arose as a comment and opposing to the more medical view of ADHD or autism, it started with, and the social view of ADHD and autism. And neurodiversity is in a way something that situates between both of these positions. If we look at the medical model considers ADHD a pathology, a disorder, that is largely situated within that person, that is an individual problem, and that the goal of treatment is treating ADHD symptoms, which is really inspired by the disease or disorder model, to neurotypical standards. If we look at the social model, they say, okay, ADHD is something that doesn't really exist. It's a social construct. It's something that we made up. And it's something to describe sort of the variety between people. But this label of ADHD is oppressive. It's something that causes stigma for people and can also cause sort of normal varieties in behavior to be over-medicalized. It's largely seen as a societal or an environmental problem, as that the way we view sort of normal variations of behavior as pathology, that is an environmental problem. And the way we should reduce individual variation, or that people don't fit in our society, is largely by addressing barriers imposed by society and really looking at what can be done in the environment. When you think of neurodiversity, it actually situates in between. So it does see that there's a difference. So people with ADHD is a value neutral difference in a way of being and doing. But this difference in itself is not a problem, but becomes a problem in mismatch with the environment. So disability only occurs when the environment is not optimally adapted to an individual need. And what you would do for support is improving quality of life and really what a person values, not necessarily taking away this difference, but looking at what you can change to improve the quality of life of someone. Because impairment is related to an environment that is not optimally adapted. And the goal is to change this adaptation of the environment, but also if a person finds it important to take away this difference for certain goals that someone finds important, this may be a goal that someone values and can be targeted or can be something that is a goal of support. So in that sense, the treatment or support is both individual, but also looking at what can be done in the environment. And what also is really something that sets the neurodiversity movement or the neurodiversity model, not movement, apart is that it's really an inside-out perspective, in a sense that authority is rooted in personal experience of people. So that the experience that people has is inevitably to understand how you should support and understand ADHD. While the medical and the social framework are really an outside-in perspective in which experts often think they can study ADHD from their perspective outside in, without often taking into account what people's lived experiences are. So if it's really crucial to look at this inside-out experience of what people are experiencing, how does the lived experience of ADHD match to this neurodiversity framework? As said, there's been a lot of work done in the autism field, but not that much in ADHD field. Well, ADHD is also different from autism, so it's good to look at what people with ADHD experience and how this matches either the medical framework, the social model, and the neurodiversity model. And this is exactly what we have done. So we've looked at lived experiences of people and matched them with these sort of ideas of all these frameworks. So I've done this together with Gert-Jan van Aak and with Blandine French, and this is what I will describe today. So if you look at how people experience ADHD, within the medical model, ADHD is often seen as a sort of a universal deficit, a disorder, in which it is framed as people have inattention, hyperactivity, impulsivity, and it's seen as sort of a universal thing that is there. Well, if you look in people's lived experiences, it is far more a variability in attention, in a sense that people do not always experience inattention. It's rather fluctuation. And a lot of people with ADHD would say, I would rather call it a variability in attention, in which this can go from inattentive in some ways, but sometimes also to a hyperfocus. And when we think about the hyperactivity, some people also rather value more neutral terms in the sense that they sometimes describe it an intensity in their behavior, in their speech, in their action, in their motor action, in relation to oneself and others, in which emotions are often really intertwined with this intensity. When we think of the social model, they would perhaps say, do we need to call this ADHD? Is this a concept that we need to use at all to describe this difference that is there? Do we need a unified concept to describe it? Or they perhaps would say, yeah, are you not broadening the concept from what is said within the diagnostic and diagnostic manual? And this is a quote of a young adult with ADHD that actually shows these fluctuations and how people often think that this medical framework with universal deficit does not really fit the way they experience ADHD. For example, this young adult with ADHD says, I think that deficit might not be the right word because I have an abundance of attention at times. It's just that I can't direct it. I don't get to choose what I pay attention to. Also, a key idea of the neurodiversity framework, this ADHD in itself, is often not a problem. It's value neutral, but it's really often experienced in mismatch with the environment. And in the medical framework, this is often framed as impairment. And this impairment is often seen, you have academic impairment or you have social impairment. So it's really from an individual standpoint. From the social model, this again would be seen as the impairment is largely context related. It's not in relation to a mismatch, but it's really that the context is not adapted to every individual, and that the context is not adapted to this group of people that have ADHD. When we look at the lived experiences, you really see that people say they have difficulty adjusting to these social expectations, which actually matches with the social framework, but also the internalized neurotypical expectations of how you should behave. And I think a quote here is, I do it all the time, rambling, and I never realize, and people, you can see people look at you and say, stop talking. And then I'm like, all right, stop. So this is an example of how someone really internalizes these social expectations of the neurotypical world. This mismatch with the environment can have really large consequences for people. And these consequences can be seen in that it sets off a negative interaction cycle, and often also rejection sensitivity. Often seemingly easy tasks in daily life, brushing your teeth, getting yourself ready for work, etc., can be really difficult for people with ADHD. And sort of then getting negative reactions and time over time can really set off a negative interaction cycle with your environment and trigger rejection sensitivity. And it's something that, for example, is put to words by this adult with ADHD and saying, continuously trying so hard, and then you feel disappointed in yourself because by trying so hard all the time, sooner or later you get a setback. You can't do your best all the time. And then people tell you you are worthless or you're no good. And I think, especially within the medical model, there's very little attention to these difficulties adjusting to these societal expectations, and far more to the individual impairment. So people experiencing academic impairment, social impairment, but not actually this negative interaction cycle. Also, it's good to look at how do people experience getting a diagnosis of ADHD, and how does this match with people's lived experience. Is it indeed in the medical model, ADHD is seen as a disorder, and this is something that can be really difficult for people because getting a diagnosis may trigger self-stigma, because getting something like or a diagnosis which is framed as a disorder can be seen as some people as having a flaw, setting them aside as someone that is really sick or has a disease. In that sense, it's often really difficult for people. From the social model, it's often seen that getting the label ADHD is the thing that is really difficult for people. So, and this label, or getting a sticker or label of ADHD, is the thing that triggers internal and external stigma. Not necessarily the behavior, but really getting the label. And that having a label of ADHD sets off a judging environment. And that is the thing that risks identity development and overshadows other interpretations of one functioning. And when we look at people's lived experiences with getting a diagnosis, it's often really ambivalent. It often indeed sets off self-stigma, because people see, okay, am I not good anymore because I have ADHD, seeing it as a disorder. But also, sort of getting a label can really be internalized as something, am I an imposter? Do I really need that label? So sort of the getting a label can be something that is really difficult for people because of the social model and people saying that ADHD is not a real thing. And it can be often trivialized by their environment. So that is the ambivalence that is there. On the other hand, a lot of people say that getting a diagnosis of ADHD is can give validation for their struggles in daily life, is also something that gives them recognition why they find it really hard in daily life. It can really help them renegotiate an often comprised self-image, and it really fosters relatedness with other people. So it's really an ambivalence here. And this is something that is put into words by a woman with ADHD that says, I've often heard, oh yes, you simply want to belong, don't you? Sort of the social model of is ADHD a real thing, etc., is something that is really harmful for people with ADHD if people comment about that to them. And also the more medical view of how it's really different, that if you get a diagnosis, this is something that you need to sort of, that is really difficult in the beginning, is here to put to words by an ADHD adolescent that said, in the beginning, it was very hard in a way that I felt different. I felt very weird almost. It just didn't feel like me, and I felt like a different person. But now I don't think so. First, because it's very common, and there are a lot of people who relate. And there you can see that the value of sort of finding other people, finding a tribe, also finding recognition, that's a process people often go through. And that in the beginning, getting a more medical diagnosis can be a really difficult thing. Also, that it's really something that can help them in validation, in recognition, in being kinder to themselves, is something that it's put into words by this ADHD woman that said, since I know I have ADHD, the biggest difference is that I've become kinder to myself. And that I think is ultimately the basis on which many practical issues are also going better. Also, I want to look at medication and how is that for people. Not that within the neurodiversity framework, the environment and other ways of looking at how the environment can have another way at looking at neurodiversity and at ADHD is really important. But medication is something that really sets ADHD a bit apart from, for example, autism or from dyslexia, the other neurotypes that are there, and can give us more insight in what is happening in people's experiences. And also because this is something that is really within the medical or the social model, something that is critiqued, that ADHD fosters over medication and gives some sort of social control over defiant behavior. And in the medical model, it's often seen as ADHD medication is something that cures or takes away ADHD behavior. But when you look at people's lived experience with taking medication, it's often not oppressive nor a cure. It's really a daily struggle whether or not they should take their medication. And there's huge ambivalence in people. On the one hand, it's a ticket to its acceptance in their daily life. It helps them to function in this neurotypical world. It's necessary to navigate their daily lives, to meet goals, but it also often has physical and mental side effects. They're not feeling themselves, and it can give them struggle with identity if it's also seen as something, for example, in adolescence, is that parents or teachers really say that adolescents have to take their medication, while they also, ADHD is inevitably part of who they are and something that also can be valued. And if it's only about taking away their ADHD, it can be really difficult for adolescents. And this is also something you see in the lived experience of adolescents and in adults. So this trying to fit in our society is something that you can see in this young adult with ADHD saying, I need this medication, I want this medication, I need it to survive in this world, basically. And if I don't take this medication, the world won't accept me. So this really shows how our environment is not adapted towards people with ADHD needs. And sometimes people take medication to feel accepted in our world. And it's not something that they take or want to take all the time, but it's really a daily struggle and ambivalence for them. Or another adolescent say, the way I behave and move in everyday life, it changed a lot from when I take the pill and I don't take the tablet. So it makes me think, what would have been like if I didn't have ADHD? And this is if you in the medical framework put too much emphasis on taking away the ADHD and not discussing parts of who you are valuable, and your ADHD can also be there, it's really difficult for people, because then it feels like I can't be there as a person. And also here, an example of an ADHD adolescent that takes medication really to reach the goals that he or she finds important. So medicine actually helps me to pay attention more to other people and to listen what is going on with them, because I know I would want somebody to listen to me. My communication skills have gotten sharper. So this is an adolescent with ADHD saying that. So what can we conclude? The neurodiversity model, lived experiences, and how do they match together? In people's lived experience, ADHD is not a universal deficit, as in the medical framework often is said. It's really a value-neutral difference that fluctuates and is largely disabling in mismatch with the environment. When you look at what people struggle with getting or having a diagnosis of ADHD, it's often an ambivalence. And these ambivalence really reflect the discussions between the social and medical model. Is it a flaw in myself, which is really the medical model, a disorder? Or is it something that may not be there? Can I really say I have ADHD, which is more a trivialization of the struggles they really have in daily life, which the social model is. And here you see the neurodiversity model often gives people validation of the struggles they have, but also because it's really more value neutral, it's easier for them to reconcile with their identity. And also important, it fosters relatedness, and they can help them find other people with that also have ADHD. When you look at people's experiences with medication, often people do not aim at always curing or taking away their ADHD behavior or see it as an oppressive thing all the time. ADHD is part of people's are, but in some instances, they may choose to take away or to reduce their ADHD behavior. You can see that sometimes the social aspects of wanting to fit in are really pressing people to take medication. But this is something that should really be part of a discussion with people. And in that sense, both individual and environmental aspects of addressing disability are important, because leaving everything to be addressed by changing the environment is also leaving a lot of people backed up and supported in our current society. So what does this model have for implications for support? I think an important implication is language. Also, I talked a lot about identity and what is my identity with ADHD. How can we address this environmental mismatch of this value neutral difference ADHD with the environment? And how can we have a more inside out perspective of mental health care? Language, I think language is really an important one. Of course, ADHD, Attention Deficit Hyperactivity Disorder, is the medical term of ADHD. Disorder and deficit are both in there. And there have been some attempts to look at other ways to talk about ADHD. To say, for example, attention dysregulation, hyperactivity development, variable attention stimulus trait, both have been suggested. But perhaps ADHD in itself, already has some sort of conceptual and semantic shift as more a value neutral term. Often when people talk about I have ADHD or I am ADHD, they do not consider this the D of disorder or the D of deficit. So it already has become sort of value neutral. I think it also implies to focus more on different in talking about ADHD than on deficit in disorder and disease, as the disability only arises when there's a mismatch with the environment. And if it's a difference, does it really imply that people are patients and that we should talk about symptoms, or should we just talk about ADHD behaviors? And also, if ADHD is something that is situated within a person or part of who a person is, should we then talk about an ADHD person or a person with ADHD? And I think this is really something that is someone's preference. I know, for example, within the autism field, people often talk about themselves as an autistic person. But in the ADHD field, it's more common to talk about I am someone with ADHD. And it's really important to ask or to think about what your own preference is. And if you talk to people, to ask what their preference is in talking about ADHD. And also, this is something within research that is recently also considered more and more important, to talk about ADHD in a more respectful way. I think also identity is a really important thing. If you look at people's lived experiences, you can see that people have a lot of ambivalences in their experience of ADHD, both in diagnosis and in sport. And sometimes their ADHD behavior, they value that, but also sometimes they choose to reduce or compensate their ADHD behavior. And I think meaning making of yourself with ADHD and a part of you having ADHD is really important to discuss, and to, as a professional, to discuss, but also as a person to think about, who am I with my ADHD? And I think within the field of autism, there's quite some research that the more positive identity people have with autism, the better their self-concept is, the better their well-being is, etc. And one way to do this is also looking at how peer support can help, or how experts by experience can help in mental health care, or how we can sort of support that people find each other in supporting each other. Because also this social identity is really important, and also related to better well-being. This environmental mismatch, addressing that and looking at what can be done to improve the environment mismatch is really important. So looking beyond only an individual, but also looking at partners, at peers, at workplaces, at schools, and discussing ADHD, but also how to support people with ADHD, how partners can help, how workplaces can be better adapted, how schools can be better adapted is really important. But also discussing it in a sense in healthcare is really important. And this is something that an ADHD woman said: I really missed that community aspect or that social aspect of ADHD in my therapy. Not that therapy was bad, it really helped me a lot, but it was very much about me as an individual and what I can improve. I myself am convinced that it's not just a disorder, but also something in relation to society. I actually really miss the conversation about what it means to be a neurodivergent person in that world. And I think what really sets apart the neurodiversity framework from the medical model and the social model that it builds on people's lived experiences, and it really sees lived experiences as expert evidence. And in that sense, looking at how experts by experience can be used more, how this can be fostered. For example, networks like this, ADHD Europe, are really important. And also can give a lot of insight into tension between neurotypical clinicians and neurodivergent people, and can help identify the blind spots, for example, in not only in the mental health care systems, but also in other systems. And this is something that is put to words by an ADHD adult that said the diagnostic process to get a diagnosis of ADHD is almost designed to play against the symptoms of ADHD due to its complex and time-intensive nature. So in sum, the neurodiversity model largely matches people's lived experiences and has quite some implications for current support. It really gives a central role to people's lived experience and gives more an inside-out perspective in how we should look at ADHD and how we should really see how we can cooperate with people with ADHD, how we can improve and talk about ADHD as a concept, but also to people with ADHD. That identity is a really important thing to address and to talk about with people and think about, and that moving beyond the individual to also partners, peers, workplaces, schools, but also societal political action to improve the lives of people with ADHD is really important.